Hello and welcome to today's community webinar. We are going to be presenting on a collaborative approach to navigating cognitive challenges with LSVT LOUD, speech therapy, and LSVT BIG, which is a physical and occupational therapy. And we're very excited to be here with you today. You may be joining us in the afternoon, or depending if you perhaps are overseas, it might be in the evening. And so we're excited to have everyone joining us today. I am presenting today with my wonderful colleague, Julia Wood. She is an occupational therapist. I am Heather Hodges, and I am a speech language pathologist. We are both LSVT faculty. Julia is LSVT BIG faculty. I am LSVT LOUD faculty, and we both work as consultants with LSVT Global. We do have some information here and in the handout on our biographies if you want to learn more about us. We both have clinical experience in hospital and outpatient settings, as well as being trainers for LSVT LOUD and LSVT BIG certification courses. We have some disclosures, some business side of things to share with you. We want to fully disclose that we have a non-financial relationship with LSVT Global, and that includes our preference for LSVT LOUD and LSVT BIG as treatment techniques. We also have financial relationships. They are the same, as we are both consultants for LSVT Global. We receive lecture honorarium for presentations that we participate in. Some logistics about the webinar. During the presentation, your microphones will be muted. We will go through in a moment a specific slide on how to ask questions during and after the webinar. The handouts, you should have received a handout in your email prior to today's webinar, but I will also put it in the chat so you can access it that way as well. And there is a survey that will pop up at the end of today's webinar that we ask you to please fill out. It's pretty fast, should just take maybe 5 minutes. If you are not able to fill it out at the end of the webinar, it will also be emailed to you, so you have that opportunity after the fact as well. And for those professionals joining us today, we have a few words about continuing education credits. So we, the LSVT Global webinar, as far as speech pathologists and then also occupational and physical therapists, we have some detailed information on this slide. And perhaps you're watching live today, or you may be watching this webinar on demand. And so we have some information here. If you need a certificate of completion, you will need to complete these surveys. It can take a couple of weeks to get the certificate processed and sent over to you. If you have any questions or did not receive your certificate, you want to check on it, you can email us at webinars@lsvtglobal.com, which is listed in this slide. And we want to just recognize that licensing requirements for CEUs differ by state. So check with your specific state for physical therapists, occupational therapists, or speech licensing boards to determine if non-registered CEUs or non-pre-approved CEU activities are submittable to your board. And attendance is required for the full hour to earn your certificate. All right, the learning objectives for all of our members today include at the conclusion of this webinar that you will be able to describe LSVT BIG and LSVT LOUD treatment protocols and how they may be modified to support treatment of individuals with varying levels of cognitive impairment. We also anticipate that you'll be able to define cognitive symptoms associated with Parkinson's disease, how they can impact function, and how they differ from other types of dementia. And lastly, that you will be able to identify strategies for use in the home and in the clinic to support successful engagement in LSVT BIG and LSVT LOUD protocols despite cognitive changes due to Parkinson's disease. So questions, if you have questions that crop up during the webinar, please use the Q&A box. There's a little icon in the meeting. You may have to move your cursor around a little bit for that icon to show up, but there is a Q&A box on your control panel that you can type your message in. Or after the webinar, if a question occurs to you after the fact, or if you just prefer to email your question in, you can do so at info@lsvtglobal.com. We'll make sure that your question gets routed to the appropriate expert, the appropriate discipline or clinician specific, so that we can answer that question fully. All right, so I want to take a moment and just find out who's joining us today. So I'm going to be launching a poll. You should see it come up here in just a moment. And we just simply want to know, are you a person with Parkinson's or another neurological condition? Are you a friend, a family member, a caregiver of somebody with Parkinson's? Are you a certified clinician, whether that be in LSVT LOUD or LSVT BIG? Perhaps you may be a non-LSVT certified health professional or student, or other. So I'm just going to take a moment longer, let everybody have a chance to click the appropriate box for them, and we'll close the poll here in just a moment. All right. Thank you so much for responding. It looks like we have a really nice mix of people across all of these categories joining us today, which is wonderful news. That makes us really happy to see a variety of folks that are engaging. So first, what we'll do is start off with an overview of LSVT LOUD and LSVT BIG. For some of the certified clinicians, this may be repeat information, but I still think it's really important to hear this again because we're going to be talking about it in the context and the framework of working with individuals with cognitive impairment. And of course, for those other folks in the community, students or non-certified clinicians, this will be a great overview for you to have as we discuss the framework of the treatment applicability to this population. So both treatments, BIG and LOUD, are intensive. They are exercise-based programs and they are standardized. So that's really helpful for the research that's occurred. It's also really helpful in delivering consistent treatment to each patient. The therapies are high effort. Your patients, your family members receiving these therapies are going to have a workout. LSVT BIG is a body movement therapy, focused therapy, and this is going to be delivered by certified occupational therapists and or physical therapists. LSVT LOUD is a voice or speech treatment, and that's going to be delivered by certified speech language pathologists. They are prescribed. They have a specific dosage and specific methods of delivery. So these treatments each are both 4 days a week for 4 weeks. So 16 total treatment sessions that occur within 1 month. And they are 60 minutes in length and are one-on-one. It is not group therapy. It is intensive one-on-one treatment. And what is unique about these therapies? Well, when we look at Parkinson's, we know that PD makes movements slower and smaller, and it makes the voice softer or quieter. LSVT, either treatment, both treatments, really, I should say, LSVT counteracts this element of Parkinson's by training bigger, more normal movements and a louder, healthier voice for patients. The treatment also considers not just the motor symptoms of Parkinson's disease, but also the non-motor symptoms that are common to occur within PD, and this includes cognitive changes and impairments. It is individualized, so although there is a treatment protocol to it, it is individualized to each person. It is tailored to each patient's goals, each patient's strengths and needs, and it is one-on-one intensive training to work on the things that really matter to the person receiving treatment. It's very patient-focused, patient-driven, and are based upon the patient's goals, the family members' goals, etc. And what's really unique and pretty awesome is that there is 30 plus years of scientific research on Parkinson's disease with application as well to other neurological disorders. And I can't stress enough how these two elements are really key and really are one of the reasons that this therapy works so well for individuals with cognitive involvement. Standardized, yet individualized. As I mentioned, it is customized to the unique goals of each individual, and it absolutely can and will be adapted or progressed to meet each person's needs across the entire range of disease severity and presenting impairments. So we truly look at the whole person. We take the abilities and challenges that they're coming into treatment with, and we developed the treatment plan around them. There's 3 key features to LSVT LOUD and LSVT BIG, and these key features are standardized within the treatment, they are research-based, and they involve specific protocols. The first is target, the idea of what is the treatment target, and it's bigness in the body, in the movement, and loudness in the voice. Both of those elements work on amplitude. We're making the voice bigger. We're making movements bigger again. And so that's what the commonality between the two is. We are focusing on amplitude so that people who feel like they're moving in a normal range of motion, but actually are very small in their movements, in their gait, in their walking, their trunk rotation, etc. And for those patients who feel like they are talking at a normal loudness when in fact they're quite whispered, or when we get them to move big within actually a normal level of bigness, or to talk louder within a normal loudness level, they feel like they're moving way too big and that they're yelling at people when in fact they sound at a normal volume and they look completely natural in their movement. So target is amplitude. The mode is intensive. It is an exercise program. Patients are going to feel like they get a workout. And yes, the body workout as well as the voice workout. We can exercise in both protocols, in both treatments. And that's actually one of the goals. We want to be able to push to that good exercise feeling like you got a workout. So it's going to be high effort. And we also work on that calibration. I mentioned that patients feel like they are moving normally, speaking normally, when in fact everything is small. Movements are small, voice is small. And so we can't just improve the performance of movement or voice. We have to recalibrate these individuals. And this is really the key for the solution for lasting success, is to calibrate our patients so they recognize that they are not yelling when they are at a normal volume and that they are not looking ridiculous when they're actually walking, moving, rotating in a completely normal range of motion that looks very natural and safer. So these schematics are a really nice example of how we're targeting amplitude. On the left, you see a voice system, and it's the whole motor speech system, from breath to voice box, to articulation, even brain activation, neuroplasticity has been examined in the research, and we see very small, very shrunken speech, resulting in very quiet voice. Motor-wise, body-wise, we see very small movement, perhaps issues with gait and balance as well, the need for a cane or another assistive device to be able to walk safely. And then through this single target of amplitude, you see on the right side what happens during therapy, what is happening at the end of the therapy protocols, and what continues to improve for many individuals. They have a motor speech system that is now nice and robust and healthy, and we see body movement that is tremendously improved, both in function and safety-wise, that healthy amplitude for movement. So this therapy, in terms of mode being intensive, it's of course going to be intensive because you're having therapy 4 days a week for 4 weeks at minimum. Some patients require more for true efficacy. And it's 60 minutes, so it's a big workout. That certainly is intense all by itself. But we are also going to in a very fun and supportive way, we push for multiple repetitions, for improving and improving and improving in movement, in voice, exercises, etc. So it's a workout from that component too. Both programs also will have daily homework, practice, and carryover exercise for the entire month of treatment. It's not just on your treatment days or on your weekends. You are doing homework and carryover activities on your off days as well. So all 30 days of the month, you're doing some home practice so that you really get some good routines developed, and those routines are going to be continued even after discharge. After your 4 weeks with your therapists, you're going to continue with that exercise program so you maintain gains and perhaps even continue to improve. We do see that. Both therapies are delivered by specially trained and certified physical and occupational therapists who are delivering LSVT BIG, and LSVT LOUD is with certified speech therapists. The goal of these therapies is really nicely and concisely summarized here. Individuals will use bigger movements or louder voice automatically in their daily living, and they are able to maintain these bigger movements or louder voice over time. This is the goal for those 4 weeks of treatment. So specifically, what does LSVT LOUD improve? It's so much more than just loudness. We are certainly targeting loudness in therapy, but what's so cool to see is that by just targeting loudness, we see increased amplitude of movement from here on up. We see that increased movement across the motor speech system. We see improved initiation of voice, vocal endurance, so that patients aren't tired of talking by the time it's dinner. They don't have that fatigue. They also have improved breath support for speech. Their articulation, their clarity is improved. Facial expression, we have great research on how facial expression, which is so engaging when you're in a conversation, that is improved. That masked face kind of effect of Parkinson's melts away through treatment. Intonation and communicative confidence. In LSVT BIG, we also see improvement, not just in bigger movement, and certainly that amplitude and that size of movement is important, but also the speed of movement improves. Starting and stopping becomes more fluid. You don't have delays or freezing. We see that changing directions when on a course improves. Endurance is going to improve, and so are balance and posture. That certainly helps with safety and mitigating fall risk. Activities of daily living improve, walking, and mood. Exercise has an effect on how we feel, and having More confidence too within our movements is also going to help mood. Now, in today's presentation, we recognize that cognitive impairment can be affected by other non-motor symptoms of Parkinson's disease. And so we really want to acknowledge that depression, apathy, anxiety, those have, kind of a mixed relationship with cognitive impairment. They can go both ways, either way. They can affect each other, as can pain, sensory deficits, visual spatial changes, and so can sleep disorders and fatigue. So we recognize this interplay of how all of these non-motor symptoms can affect our cognitive impairment, but also that cognitive impairment can affect these other elements in our lives as well. The focus of our presentation today will be more on the cognitive changes that occur, but we did just want to acknowledge that there is an interplay between all of these factors. So, why does it matter? Why do we need to consider cognitive symptoms? Well, first of all, they are a potential barrier for generalization of these great treatment gains that occur in the treatment room. We don't want them to disappear when the patient leaves our treatment room. So we have to address them as a potential barrier to generalization so that we can truly open the door to improved movement and voice outside of the therapy room. They are also part of the reason behind the high intensity of these programs, of these treatments. We need repetition. We need salience. Salience is the individual, meaningful ways in which we are working on patients' goals. We are working within their areas of interest and their functional lives. And so we know that they are a part of why we need intensive therapy. And we also need to view our patients as from a whole person perspective. We need to be looking at not just their speech, not just their motor movement, but we need to look at the full person so that we can help tackle barriers, we can help adapt, we can personalize further, and we can progress patients through treatment in an appropriate manner when we know that there is a cognitive involvement. So it's important to consider these symptoms. Why does LSVT, these big and loud, why do LSVT treatments work so well for people with cognitive impairments? And that's because these therapies provide simplicity. There's repetition, so there's a familiarity that comes with repetition of cueing. They get a lot of practice during their time with us. It's individualized, and so that's a huge reason. If we make something meaningful, that's going to be motivating, and we are looking at the whole person that way. These exercises directly are used to improve function. We're not doing, random like oral motor exercises to try to improve voice. We're working on voice. Quiet voice is the issue, so we are being very intentional with improving that function. And the same is true with BIG, addressing body movement, gait, balance, etc. Intensive exercise works really well for individuals with cognitive impairments. And these therapists are going to be motivating, they're going to be empowering, they're going to give the confidence back to our patients so that they know they can do it, they will do it, they have that success, and they can even do it when they're not with their therapist. So we're very engaged. The tasks are going to be meaningful to them, that salience factor, and they're going to be specific. If you need help working with doing laundry, if you need help with asking a question to go to the bathroom, we're going to work on that. We're going to work on what's specific to that person. And what's really nice and important too for our whole audience to know is that these techniques are easy for care partners to learn and learn how to appropriately cue their loved one or their client on the techniques so that they can use them outside of the therapy room. So that's absolutely an important part of the treatment as well. So, with that framework, with that background, I'm going to turn things over to Julia. And so she will be taking over the next session. Just going to change remote control. All right. Oh, and let me.
Excellent. Thank you so much, Heather, for the great introduction. That was fantastic. And so we're going to launch in and talk a little bit more about what these specific cognitive changes look like in Parkinson's disease, because understanding them, I think, really helps understand more the types of therapy that are important and the types of modifications sometimes. Something that I sadly hear a lot at LBDA is that people are referred to therapy by their doctor. And before the therapist even sees them, without an evaluation, even sometimes they'll turn them away if they have Lewy body dementia, for example, or one of the dementia presentations with Parkinson's. So, we're going to talk about how that's really not right and how you might have to advocate sometimes for your care. Okay, so what do these cognitive symptoms look like? Well, really, it the ones that we're going to highlight are a lot of what we see, and you want to think about them in a spectrum over time, right? So, what we're talking about in this first slide here, really early on, even people with kind of untreated Parkinson's, we note that they can have impaired processing speed. So, they don't necessarily have a cognitive impairment yet, but they may notice that change of feeling like their thinking is slower. They might also notice that they're having more trouble and difficulty with concentration and attention. And so this can impact things like multitasking, which you notice over on the other side of the screen there. Also, some visuospatial impairments can be present early on. So, judging depth, negotiating, stepping down from a curb, or maybe where a cup is and sitting in relationship on the edge of a counter. Executive dysfunction refers to things that we have to do a lot of times for work tasks or even in the home. So, following steps, sequencing, processing, following a recipe, completing a piece of IKEA furniture or doing a work task. And then sometimes we also see some memory impairments. And it's important to note that with Parkinson's, these are more working memory related rather than like the memory changes that we think about with like Alzheimer's, where you're having more of a amnestic type presentation. Um, just like Heather mentioned, the cognitive symptoms can really be impacted by a lot of the other motor and non motor symptoms. So, fatigue, one of the most often reported non motor symptoms in Parkinson's, can really exacerbate cognition. And also, cognitive fatigue is something that we hear people complain about a lot, or maybe their body doesn't even feel that tired, but in trying to sustain attention on a task or watching a show for a long period of time or doing work on the computer, they might feel more distractible, or maybe that their thinking is slower, and that's that bradyphrenia, that slow processing speed. And we also know sometimes that people can have some perseveration with their with their thinking, and maybe get stuck on an aspect of a task or stuck somehow in a task as they're trying to shift and move into another task. And often we may find that people have a reliance on external cues, and that cued recall is something that can be really helpful for people. This impaired access sometimes to working memory, or this slower access to working memory, can make doing a task and really multitasking, moving from task to task, more difficult. And sometimes we see an exacerbation with things like apathy, fatigue. So there might be some decreased initiative as well. And when you think about that, how that can impact function and problem solving, you'll notice that here on the right hand side of the screen. So, some difficulty with mental flexibility, considering multiple solutions, looking at things in different ways. And this can impact decision making overall. Sometimes people can have, and this can be really early on. People will sometimes describe this before they're even diagnosed, that they notice some trouble initiating tasks, planning, kind of organizing how to complete that task. And then along with that comes a decreased ability to self evaluate feedback. So these symptoms can be very early on and kind of higher level, and when someone's younger and maybe early in the disease process. And we'll talk about what it looks like as these changes progress over time. So we talk about attention. I've kind of noted this a lot here, those concentration challenges, being less aware of surroundings. Sometimes people don't have trouble noticing social cues, and this can mimic memory loss. So sometimes people will report and describe or feel like my memory is just not what it used to be. But if you think about it, if we're at a party and you're telling me your name, but I'm watching the tray of hors d'oeuvres walking by, then it's not really that I have a memory problem when I can't remember what you said. I wasn't really paying attention. I was distracted by something else. We talked about executive functioning a lot there. Those analytical skills can really decline as well. And I think the important thing for this talk here is this can really present with more difficulty when someone feels rushed or under pressure. And so I think that's both for the care partner to be aware of and for therapists, even that we don't want to rush or pressure or try to get someone to move faster. And we want to allow more time, really giving some pause and patience. But also for those of you out there with Parkinson's, I worked on a skill called time pressure management a lot with my clients as a therapist, where you really think about the amount of time it takes for you to complete a task. And a lot of times that's gotten longer, and maybe it's taking longer due to the slower movements and the slower thinking. So, not creating those time pressures in our daily life as well. So the visuospatial skills, this is something that we don't know what we can't see, right? So you aren't necessarily going to notice that you're having a reduced sense of distance between objects. Now, your loved one that's riding in the car with you might notice that you're getting too close to the other vehicle, or maybe they're noticing that that glass is really close to the edge of the coffee table. And so that may not be something that you really know, but maybe others can point it out to you, and it's something to discuss. Sense of direction can become impaired, so that could be within the home or even navigating out in the community. And it's important to note that this can really be both in the brain and in the visual system. So, the eyes are having to coordinate with tiny little muscles to send those signals into the brain of what we're seeing. But then our brain also has to pick that up and perceive it. And so we also see a lot of times some double vision or diplopia, where people might see double of something, and also a loss of color contrast. So, kind of watching in your home that if there are areas where you're having falls or maybe some issues with movement, sometimes looking at the lighting, even, or the contrast, how much is your brain able to pick up? We talk about language. This is a lot of what Heather was talking about, having some of that disorganized speech in a conversation, and also difficulty processing words spoken. So that slow processing a lot of times can really impact conversation, especially the more people that are talking, or maybe the rapidity of the conversation, if it's moving back and forth pretty quickly or changing topics. And as I said, that memory loss may not be really apparent in early LBD. And a lot of times it's more attention based. And important to note that cued recall a lot of times can really help people with Parkinson's. So giving those cues, like Heather mentioned, and coming and learning those and working with a therapist on what those cues might look like. This is something so important to know. This is a hallmark of Parkinson's related cognitive changes, and it's what we call cognitive fluctuations. And so, what these look like is that one minute somebody is completely fine, right? They might have this moment of clarity, they're responding maybe rather quickly, maybe they're really alert. Just very much seem with it, right? So some call this showtime. And of course, this can happen with medical professionals, or maybe you've been talking to your family about, wow, they're really struggling. Like he seems really confused all the time. And then they show up and your loved one's fine. So they're not faking it. This is a real part and parcel of Parkinson's disease is this fluctuating level of concentration and attention. So it can go from that moment of showtime with the doctor or where someone looks really, really with it, all the way into these episodes of confusion, kind of looking zoned out. This can sometimes interweave with excessive daytime sleepiness. So somebody really dozing a lot in the chair. And so important to know that it can change minute to minute, day to day, hour to hour. And it's one of the more frustrating aspects a lot of times for people living with Parkinson's and cognitive changes. So I've already talked about some of these higher level function issues. So think about slower response time, right? So try not to get frustrated, with people when they don't wait for you to respond. But I do encourage you to have conversations with your family. And this is something a lot of times your speech therapist and your OT can talk about is kind of understanding that need for increased processing time. And this can go around some of these language challenges too, right? That delayed word retrieval where, it's a farm animal, but it's got hooves and a tail, but they're having a hard time coming up with that word. Sometimes we'll call it tip of the tongue syndrome. Difficulty shifting those topics, like I mentioned, trouble initiating and expanding on a conversation. So sometimes their responses might seem a little bit more flat. And then I mentioned those difficulties with language processing too. And so I think this slower processing is so important for us to remember as family members, right? As loved ones, as friends of someone living with this, trying to slow our roll a little bit and allow a little more time for processing. And also for the therapist out there when we're cueing, when we're working with individuals with Parkinson's, thinking about taking it a little bit more slowly. Those visual spatial changes that I mentioned, just important to note that often they happen independent of visual acuity. So this isn't something necessarily that an optometrist is going to find out. If you're having a lot of issues with your vision and Parkinson's, you might want to try to see a neuro-ophthalmologist, which is like a specialist in neurological conditions and how they affect the eye. So the thing to note here is that these do seem to really interplay with motor planning, with freezing of gait. So if you have issues with start hesitation with your walking, and then also with postural instability. So really important to have your vision looked at, to discuss these changes, to have a good OT in your team, and take these into consideration in your home for safety, and also with your LSVT protocol. So it's important to note that, if we're thinking about these cognitive changes and we're thinking about how to maybe make our life more simple around it, right? Or our treatment setting more simple. There's some things that you can kind of remove and think of a little bit to make it easier. So kind of keeping the cognitive and the linguistic complexity down. So the more that goes up, the more difficulty someone may have. If they're doing a dual motor task, so trying to carry something and carry on a conversation at the same time, that can make things more challenging. If there's a lot of external distractions, so like at a busy restaurant or in some kind of, maybe having all of the family over for a holiday and there's tons of people in the house and you wonder why they kind of shut down and aren't talking. Um, if conversations take that quick turn, like I mentioned earlier, that makes a lot more difficulty. So, kind of transitioning conversations with your loved one and even cueing and how we're working through maybe some training for LSVT. Maybe you're the care partner and helping, or you're the therapist, but really trying to make those gradual shifts in topic. If a conversational topic is unknown or not predictable, that's more difficult. If there's multiple people in on the conversation, so the more people involved, that makes it hard. And then also if the individual has anxiety or depression. And so I think it's really important to remember that these changes to mood are part of the changes of the brain in Parkinson's, or can be for a lot of people too. So important to talk with your doctor about those. All right, so I want to try to clear up some confusion here with Lewy body dementia, hopefully not make you more confused, but I want you to think about it like a chicken and an egg under an umbrella. So, what do we mean by that? Oops, I went the wrong way. What I want you to think of is the umbrella here is Lewy body dementia, right? And the chicken or the egg is going to be what type of Lewy body dementia we call it. So basically, we go by this 1 year rule, right? So Lewy body dementia is our umbrella up here. If you look over to the side, if we have people who have had, well established Parkinson's for some time, for at least a year, right? And then we know, unfortunately, in research, it suggests that around 50 to 80% of people over time will develop dementia with their Parkinson's disease. So that's called Parkinson's disease dementia. So the person had Parkinson's first, and then across the disease span, now they have dementia with it. So they've got PDD. For some people, the dementia will start first. So when we talk about dementia, it's not Alzheimer's. In our culture, unfortunately, those terms have been used interchangeably. Dementia is actually a clinical presentation of a lot of different types of diseases, like Alzheimer's, sometimes from vascular dementia, like strokes, frontotemporal dementia, Lewy body dementia. So all that means is cognitive changes that are significant enough to impact your daily function. So, in the case of dementia with Lewy bodies, that dementia happens prior to these changes to movement or Parkinsonism. So, the dementia came first. So, it's dementia with Lewy bodies, right? It's important to note these conditions share the same biology. So, alpha synuclein is this protein that makes a clump, and it's like it clogs up the interstate highway in our brain, and then it's harder for those signals for those trucks to get through, and that's the cause of, or we think that is present with Parkinson's disease and with these Lewy body dementias. So a lot of confusion out there around this. So, how do they differ? Like I said, Alzheimer's prominent memory problems affects the ability to store new information. So, if someone tells you, well, you can't possibly remember an exercise program because you have dementia, they're thinking about Alzheimer's disease. And once again, they're not the same. You see more gradual changes to memory and thinking, and then physical symptoms more in the later stages of Alzheimer's. With Louis, we see that memory is typically spared more in the beginning. Now, later on, it might become more of a problem. And like I said, that working memory related to attention can be an issue. We see those fluctuating abilities to think and remember, that fluctuating cognition and attention and alertness, issues with problem solving, attention, reasoning. The physical symptoms may be present at all stages. So they may have some Parkinsonism at the same time that they're having their dementia symptoms. And then this can also include hallucinations and also what we call REM sleep behavior disorder, where someone can act out their dreams when usually they would not be able to move. So, very, very different. And just to point out how incredibly different, top bar graph here are people with Alzheimer's who took a bunch of different neuropsych tests. So they looked at memory, their attention and executive function, language, visuospatial function, and they compared that to the bottom group, which is people with dementia with Lewy bodies who did the exact same assessments. Now take a look. Let's say that you went to your primary doctor and they did a dementia rating scale. That's that black bar over at the far left. So exactly the same. So this is where a lot of times people with Lewy might be misdiagnosed with Alzheimer's or vice versa. But you notice that's where the similarities end. When we move into those red bars with memory, look how much lower those scores are for people with Alzheimer's. Those green bars moving over for language, notice how different they are for Lewy and Alzheimer's. The one with Alzheimer's that's high is low for Lewy and vice versa. Moving over to the yellow ones for executive function and attention, you notice how high they are up at the top for Alzheimer's and how low they are at the bottom for those folks with Lewy. And then last, those blue bars represent visuospatial function assessments. Top bars for Alzheimer's, really high, right? Bottom scores with Lewy, not so much. So they are literally opposite a lot of times in how they present. So please out there, clinicians, if you're used to treating people with Alzheimer's, don't assume people with Lewy are like people with Alzheimer's. And don't assume that all dementia is Alzheimer's. And that's for all of us to learn. So I think I already kind of covered this, and that trouble, sometimes understanding directions. But this can also be the pace that we're speaking to someone. So you might want to ask your therapist or therapist, you want to try to remember to try to slow it down a little bit. They may have some limits to new learning and carryover, so they might need a longer course of therapy. We'll talk about some of that, maybe more caregiver support and cueing. They may not be as aware of some of their deficits. So we might have to work a little bit more on that sensory awareness and that calibration piece. Sometimes they can even have some difficulty with utensil use or some apraxias where using different types of utensils might be difficult. And then we also want to think too that safety can really be impacted here. That could be swallowing safety, that could also be falls risk. So, really keeping that in mind with all of the therapeutic interventions. All right, so some stages, some strategies here for at home. I think really looking at, coaching in if someone's confused or maybe having trouble wanting to get together to go to therapy. Sometimes having a picture schedule, we'll talk about that, orienting them to where you're going, what you're doing. Sometimes we need to increase the dosage of treatments. We might need to do more than 4 weeks of treatment. We want to be sure that we're really thinking about those meaningful salient activities. So I encourage you when you go into therapy, think of things that you love, things you love to do, things that you might want to try to do again. Um, you always want to look at ways we can reduce distractibility, with attention being such of an underlying cognitive issue for most people with Parkinson's. Trying to reduce those attentional demands is so important. Be patient with yourself, with your clients with Parkinson's, with your loved ones with Parkinson's. Allow that time for that processing to happen. And for therapists out there, and even for care partners, if you're trying to help, model the exercise, limit the verbal explanations. The more you show somebody how to move, they'll just mirror you and mimic you. It makes it easier for everyone. So, in the home, too, I think some important things to think about here: establish familiar, consistent daytime routines. Think about storing things in consistent, predictable places and maybe even marking that with a picture. Now, keep in mind with the visuospatial changes, sometimes it can't be like an icon of a sock on the sock drawer. I've had patients before that we needed the picture of the inside of the sock drawer on the outside of the sock drawer. Think about how to facilitate gradual transitions. Like maybe you have a song for when it's time to go to LSVT Big or LSVT Loud that you play, or a song when it's time to go to the shower or do some chore. Really keep your cues simple. Keep tasks simple. Think of simplifying and breaking down things. It can be helpful to keep a calendar or some kind of a schedule on the refrigerator or somewhere in a very visible place. When we think about attention, everything in our environment is competing for our attention. Every single thing on my desk is competing for my attention. Try to decrease clutter and distractions in the environment. And then I encourage people to create and maintain some type of an activity box. I think that this is so important, to keep people active, engaged, involved, doing things that they enjoy, doing things they love. It's so good for the brain. So some treatment tips here, so really thinking about directing treatment toward patient-centered, task-oriented goals. And there's been some research around this even for people with dementia, with Parkinson's related dementia. So going into therapy, if you're going to go and try to get LSVT big, LSVT loud, think of what your goals might be. What do you really want to do? What do you want to come away with? Prioritize things that are important to you. It might be some of your ADLs like bathing or dressing or grooming. Maybe it's things like bill pay or doing some home task for IADLs. Maybe there's some self-management things that you want to do, or even some strategies for dealing with maybe cognitive tasks in your day. And some people can really use some direct training in different cognitive strategies. If the changes are more subtle and early on, Erin Foster has done some great work in this, and Joan Toglia around kind of these metacognitive strategies for kind of planning out tasks. So when we're thinking about these cognitive concerns, as far as your treatment, as the therapist, or even as the person with, you might ask to go into a separate room from others. If you feel like you're in a big treatment gym and people are distracting you, as a therapist, you notice the person seems distracted, try to find a separate place. um, you really want to model the exercises, and so maybe you might even ask them, can you show me how to do that? If you've got a therapist that's using a lot of words, and as the therapist, try to remember to minimize that. And I always say a little less conversation, a little more action. Try to do that modeling. You can use environmental cues as a clinician. Instead of saying, okay, I need to take a big step to the right with your right foot, you can just say, take a big step toward the window and back, something like that. Repetition, 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 really practicing and driving that skill, and keep the focus simple. So we don't want to be like, okay, I need you to have a bigger right arm for me and bigger posture and a bigger step with your left foot. The more that you communicate, I want you to think of like every time you say something, this is even for care partners, it's like you've clicked that window and you get that spinny wheel on the computer, like we're waiting for the information to load. The more cues we throw at someone, the more spinny windows they've got going on as they're trying to process that information. So these environmental adaptations too, think about the best time of day. And this could be for you. What is your best time of day? When do you feel kind of your bright-eyed and bushy-tailed self? Think about the environment, and this could be in the clinic, making sure that the lighting's up in your home, maybe getting dimmer switches on the lights so you can have them up higher or lower as you need. Create a schedule. Try to really think of the day, time, and place in your home that you want to do your exercise practice, right? And also then really fitting that schedule to go see your therapist into your life as well. Involve others as much as you can. I think for everyone, we know exercise over and over and over. We've seen in research that we involve family, friends, maybe even staff where you're living. That can really, really help our motivation a lot. And a lot of times, people with cognitive changes may need more support initially, to kind of be convinced to carry over some of these targets. And that may be throughout, and that's okay. That's where having these supports from friends and family and staff can be so helpful. So we're thinking about those visual spatial deficits. I want you to really think about contrast in your environment. This could be in your clinic environment, in your home environment. If you're in a beige world, pop some color in it, because sometimes we've got a beige recliner on beige carpet with some beige walls, and then we wonder why we're reaching for furniture and trying to see. Throw a big colored pillow on it, or a colored throw, or some colored tape where they need to step on the floor, and that can be a visual target. Then having a brightly colored coaster on the table is a visual target. Educated modifications to support safety with mobility. So this might be, colored tape on the walker so they can find it, or maybe, little feet prints down the hall for them to step to take their bigger steps. And then adequate lighting is so, so, so important. And we don't want it too bright to where we're getting a glare. So sometimes those overhead can lights and things can be hard. We want to think about some low vision strategies, but really looking at how light is impacting vision for someone with Parkinson's. So your positive reinforcement out there is so important. This might be the care partner egging on your loved one to do this. This might be the therapist in treatment, but really, helping people understand, yes, the exercises are a lot of work. You're probably feeling challenged, but this is what's going to help you do all those things that you want to do. Play with your grandkids, play with the new puppy, go for a walk. And we're going to, get them to participate and be more encouraged to participate the more energetic we are. So, therapists out there, bring it up with people. All right, physical activity and active practice we know can really increase vigor. So I think sometimes we get worried like, oh, this might be too much, or maybe they need more rest, or maybe we need a lot of rest breaks. And we see a lot of times that increased activity with treatment may even help sleep. So then they start to feel better overall. Speech and swallowing treatments are also exercise. So when you're doing those, you're getting a lot of exercise. So that counts toward some of your physical activity goals. This is also going to increase endurance with daily exercise and practice and increase that engagement and socialization as well. So, what are some things about LSVT that care partners should know? I'm going to bring back Miss Heather Hodges here to jump back in and talk to us about some tips for care partners. Welcome back.
Thank you so much. Thank you. That was tremendous. I think that all of the wisdom and insights are just invaluable for our community members and our professional members to hear. So thank you so much for that, Julia. So important to know that we can see great improvements, and modeling is so huge both in the treatment room and also I love that you pointed out that it can be done at home. Show them what you want, and do what I do is really so powerful. So thank you so much, Julia.
Thank
And
you.
we are, yeah, we want to share some ideas of things that specific to care partners. And, first and foremost, when you think about the care and the expectations of the outcomes, know that earlier is better. So don't wait for symptoms to get, significantly worse. Don't wait for moderate issues to come up, or frustrations within the house to develop before you go to your doctor to talk about rehab therapies. So ask early about referrals to physical therapy, occupational therapy, speech therapy. Research shows clinically what we see matches that the earlier we can get in, the more of an impact that we can make for a longer period of time. And please know too that people with Lewy body dementia can improve their function. It's not just about compensating for their deficits. They can improve. They will improve, and they do improve. And we absolutely know that they can be empowered to be more independent, which is enormous for them. It's also going to really help with avoiding burnout of caregivers. So it's going to be a beneficial thing for everyone involved in that house. And general exercise does not replace therapy. Just if you try to find a general exercise class, or you look up videos online to do some workouts, it doesn't replace therapy. We need for individualized, tailored treatments to take place, treatments that are guided by specialized therapists in both big and loud, so that we really are targeting the specific needs, as well as treating the whole patient, and that includes using our knowledge of cognitive deficits and how we can work with them. And we also want to impart how to reinforce simple cues for individuals if you are in a caregiver role. It may be as simple as telling your loved one, think big. Oh, you're grabbing your water? Think big to do it. You're requesting something? What do you want for dinner? Can you tell it to me in your loud voice? Or think loud when you tell me what you want for dinner. Discuss what cues are working best with your LSVT therapist. Every person, like I said, it's individualized therapy. So the therapist will find the best cues to improve movement, best cues to improve voice. Julia talked about using environmental cues like take a big step towards the window rather than saying the word left or right. Ask to observe therapy. It may not be that you, and it'll depend therapist to therapist. It depends day to day on what they're working on in treatment. But observing therapy can be very helpful as well, even if it's part of it, so you know how to help them with their homework. There are also homework helper videos that are specific to LSVT Big, specific to LSVT Loud. They're not general exercises. They are specific to these therapies. And please know, exercise is medicine. It absolutely is. And so just like any other medicine, you don't just stop taking it. The same is true with exercise, big exercise, LSVT loud exercise. So after treatment, we have those homework routines so well ingrained. Your care partner might help to cue you for them, and that you really take your daily dose of LSVT big and LSVT loud. So if you take your pharmaceutical intervention, your voice exercise, your body exercise, you do all of that, and that's going to equal the best treatment combination for success. These therapies are a lifelong model of care. I mentioned in the beginning, and we've talked about it a couple of times, but this is not just 4 weeks of therapy and then you're done and you don't exercise anymore. That's the start of it. Those 4 days a week for 4 weeks for each of the 2 different treatments are the beginning. The daily self-practice that you get into the routine, that is going to be part of your lifelong model of care. And the practice at home is pretty brief, 15 minutes or so. So it's not like you're replicating a full 1 hour treatment session at home. For practice, not at all. It is a shortened version of practice that is research-based and we know will be that daily dose that you need. There are group practice offerings where people who have graduated from LSVT Loud may attend what we call Loud for Life. And these are group exercise classes that occur. And the same is true for those who go through LSVT Big. There's Big for Life. And so they're really wonderful classes to take part in. And scheduled tune-ups. Sometimes people do need a little check-in. Maybe they need a couple of treatment sessions, 3 months, 12 months. Your therapist will be checking in with you after treatment, and you'll have those potential for tune-ups if you need them. It's usually not that you have to do all 16 sessions again. It's usually just a couple, 2 to 6 treatment sessions to get back on track or to recalibrate yourself. Insurance coverage, we find that these treatments are typically covered by medical insurance. The percentages of coverage will vary, so check your individual policy. And most Medicare age plans focus on the medical necessity to determine coverage. And so your therapist will make a great case for that in their documentation so that you are improved. I worked in a hospital setting for 13 years. I always got Medicare approval for my sessions. And so in summary, cognitive changes and dementia are common in Parkinson's disease at all stages, and they may affect body movement, gait, communication, quality of life. But we can impact these symptoms both directly and indirectly with our treatments. And those with cognitive involvement can improve with therapy. This is not a maintenance program. This is going to be an improvement. This is therapy that aims to improve. And care partners can be trained to assist at home in ways that are straightforward. It reduces frustration in the house, and it reduces care partner burden. The strategies with your LSVT therapists may include high intensity, exercise repetition, environmental adaptation, a lot of positive reinforcement and arousal, and we make it a lot of fun. The 4 weeks go really fast because time flies when you're having fun. And it truly is. We get to really engage and everyone has fun, including the patient and the therapist alike. The tasks are salient, They are engaging. If anybody, gives you boring exercises, boring stimuli, boring functional carryover tasks that are not having to do with your goals or your interests, then that is not part of what a successful protocol will be. So they are salient, engaging tasks, and they are exercise. They are physical activity. They are a workout. And so, with that, we are at the end of our presentation. Thanks for staying a few minutes longer. When you exit, the survey will pop up for you automatically. And so you should see that displayed on your screen directly after. We'd love your feedback. If you are not able to do it right now, it will also be emailed out to you probably the tomorrow, so you can be on the lookout for that. For those of you who are taking this on demand after the live course has already happened, the survey link can be found below the webinar description for each of the webinars in the section online. And that will be at the blog.lsvtglobal.com. And there's also those of you who are viewing on YouTube, you'll see the survey underneath that description. Please email us if you have any difficulty finding the survey. And also, if you are not able to find the link, let us know. And these steps are required to receive a certificate. So if you are going to be applying this to your CEU activity and want that certificate, it is required. And it can take a week or two to get the certificate. The survey itself is pretty fast, should take 5 minutes or less to complete. And as a reminder, here are ways to get in touch with us. I think we have all of the questions that were submitted in the Q&A. Those were addressed. And so if you have further questions that come up, or you wake up tomorrow thinking about LSVT and you have that question pop into your head, you can email us info@lsvtglobal.com. You can also find a lot of great resources at our website. So thank you so much. Thank you to my co-presenter, Julia. It's always a pleasure, and we really enjoyed spending the webinar with everybody.
Thank you, Heather. Thanks,
Thank
everyone.
you. Take care.
Bye.